And sometimes, even if none of these maneuvers help, then you have to go for the third line management, that is applying the digital pressure to fracture the clavicle, or go for the symphysiotomy or a Zavanelli's maneuver, where you push entire head back into the pelvis and go with the cesarean section. Or you can go with the laparotomy and hysterotomy, followed by disimpacting the anterior shoulder and then perform the vaginal delivery. And I know all these are not very easy to do it. It's very difficult. I think the regular drills are required for this. And I'm going to take you through one of the medico-legal case. Here, the Nadine Montgomery is a type 1 diabetic, and obviously she was very concerned with her pregnancy, and she did discuss with her obstetrician that she is having fear of childbirth, and the obstetrician did mention that she has risk of having shoulder dystocia. And this lady was allowed to go for vaginal delivery and had the vaginal delivery, and the baby sustained the HIE because there was delivery of nearly 12 minutes between the head delivery and the entire baby delivery. And then mother put the case on the obstetrician, saying that she was not given the entire picture of this shoulder dystocia. She was given just mentioned shoulder dystocia can happen, but what are the serious complications like HIE and brachial plexus injury, all this was not mentioned to her. And she won the case. So this is the regular checklist we need to follow for the shoulder dystocia. And the next emergency, which we all fear about, is the umbilical cord prolapse, where the umbilical cord comes out between the presenting part through the cervical canal into the vagina. And this occurs in 0.5% of the deliveries, and it is more common in non-cephalic presentations and multiple pregnancies. And it carries the mortality rate of 1%. And so the risk factors are mainly abnormal presentation, long umbilical cord multiparity. And how do we diagnose this condition? Most of the time, the patient themselves may come that something is coming out from their vagina, and then when you examine, it would be the umbilical cord. And it's also very common that sometimes we are doing the induction of labor, we perform the ARM, and then you start seeing the changes in the CTG. And the CTG may show that there are variable decelerations, or there is a sudden bradycardia that has happened after the beautiful normal CTG. Then that indicates that after you have ruptured the membranes, the cord might have come down, and that is the reason the bradycardia is happening. So how do we manage this condition? So you have to always call for help. And whom do you call? It's obstetrician, your midwife, or the labor nurses, neonatologist, anesthetist, and theater staff. And obviously, you have to state clearly all the time in the emergency what you are dealing with. This is a cord prolapse. Prepare for emergency delivery and start resuscitating the mother and the baby. So the first resuscitation maneuver is the manual elevation of the presenting part. That is, put your hand into the vagina, push the presenting part away from the cord. Or we can do the Trendelenburg position or the knee chest position. By that time, I think if somebody is able to help you to get the Foley's catheter and the saline, then start inflating the bladder with the saline up to 500 to 700 ml of saline. And then administer the tocolytic and start shifting the patient to the theater as soon as possible. And after going to the theater, we always have a dilemma. Shall I get the spinal or shall I get the general anesthetic, because it is an emergency? Obviously, if you have very skilled anesthetist on board, you can always go for the spinal anesthesia, and who can give you very quickly anesthetic. If not, you can always go for general anesthetic. If she is fully dilated, easily we can deliver from vagina, you can do the instrumental delivery, but obviously if it is taking time, please go for cesarean section. And whenever you are transferring the patient to the theater also, it's very important that when you are applying the manual pressure, you have to go along with the patient in the same position. After you have gone to the theater, when they are giving the anesthesia, and after the anesthesia is given, when you are about to give the incision, then you have to take your hand from the vagina, or if you have inflated the bladder, just before giving the skin incision, deflate the bladder, otherwise you will be ending up with the bladder injury. So again, this is one of the case that has happened at Queen Charlotte Hospital, where they couldn't recognize immediately, and there was delay in managing the case by 25 minutes, and hence the baby had HIE, and hence the hospital had to pay out for the patient. So this is the checklist we follow for the cord prolapse. And another important obstetric emergency is the maternal collapse. It's an acute event involving cardiorespiratory system on brain, causing reduced or absent conscious level at any point during pregnancy or up to 6 weeks postpartum. And it happens, it's like 6 in 1,000 births, and most of the time it's vasovagal episodes or it is epilepsy. And our Muir's chart helps us to identify these conditions quickly. And causes of maternal collapse, 4 H's, 4 T's, most of you are aware. So whenever there is a maternal collapse, we have to go in a systematic way, that is primary survey and resuscitation, that is airway, breathing, circulation, and disability and exposure, because the airway problem can kill the mother quicker than the breathing. Breathing problem can kill the mother quicker than the circulation. So we have to follow this order. And then after the primary survey is completed, then we assess the fetal well-being, and if we need to deliver, we'll deliver the baby at that time. After that, we have to perform the secondary survey, that is from top to toe examination and back to front examination, and definitive care is delivered after that. So why is the resuscitation very difficult in the pregnant ladies? It is because there is breast enlargement, and also there is reduced esophageal tone, and there is laryngeal edema. This makes it difficult to secure the airway. So it's very important that we secure the airway in these cases early. And also there is aortocaval compression, and again, always to relieve the aortocaval compression, we have to do the uterine displacement, or we have to tilt the table by 15 to 30 degrees. And again, uterus gets about more than 10% of the blood flow of the circulating volume, so there is more risk of bleeding, more hypovolemia chances, so we have to do aggressive fluid resuscitation. And there is dilutional anemia in pregnancy and decreased oxygen carrying capacity, so it is mothers develop very quickly the hypoxia, so it's very important that we give the high flow oxygen. So this is how we do the uterine displacement.